I'm going to ask Dr. Duchin to come up to introduce the section on general recommendations on immunization.
Thank you, Dr. Tempte, and good morning. I'm going to be very brief because the information that I typically present in the introduction will be covered by Dr. Kroger in more detail. Just a reminder that this is one of the ongoing updates of the ACIP regarding the revisions of the general recommendation, which occur over a prolonged period. Is quite a comprehensive and detailed process. And so you're familiar with what the general recommendations are and who the target audience is, so I'm not going to review that with you today, but if you're interested, you can find the document on the ACIP website. We've gone through a number of topics with the ACIP already, and there are a number to go. Today, we'll be looking at vaccine administration, vaccination records, and new sections and changes that will be highlighted by Dr. Kroger around vaccine administration, safety, intradermal injection route, and a very interesting discussion around nonstandard vaccination practices, particularly in patients with hemophilia. And then we'll have a presentation also from Stuart Myerburg regarding immunization information systems, clinical decision support for immunization for clinicians. Then after this body of work is completed, we have additional work to do on altered immunocompetence, storage and handling of immunobiologics and vaccination programs, and expect to present to the ACIP request a vote on the revisions in June of 2014. So with that, I'd like to ask Dr. Kroger to come up and review with us the revisions that are under discussion today.
Thank you. So today I'm going to cover general recommendations workgroup discussions on two sections of the general recs, vaccine administration and vaccination records. ACIP members should have two draft copies for each of these sections. One is in track changes and one is a clean copy. As I go through the changes that the workgroup has made to the draft, I'll be giving you some letter designations, number designations, for page and line, so you can follow accordingly. So let's start with vaccine administration, and you should have a draft that says August 23rd, 2013 at the top, left-hand corner. The three, and I'm going to cover, in the interest of time, I'm going to cover those areas which engendered a lot of discussion in the work group, but during the question and answer session, you can definitely feel free to ask questions about anything you see in the draft. So the three changes are changes to infection control and sterile technique, addition of information on intradermal route, and then vaccination route, intramuscular versus subcutaneous. So taking the first one of these, there are two components of infection control and sterile technique, which has generated some discussion in the work group. The first is in the section preparation and timely disposal. So this is on page 1 of your tracked copy. So the designations will refer to the track copy. So page 1, line 13 of your tracked copy, you'll see a section. So I'll discuss that, and then I want to talk about some of the changes we made to the language surrounding OSHA regulations with respect to preventing needle stick injuries. So you'll notice on page 1, line 15 through 22, we have new language which state, I'll read it, vaccines should be drawn up in a designated clean medication area that is not adjacent to areas where potentially contaminated items are placed. Multi-dose vials to be used for more than one patient should not be kept or accessed in the immediate patient treatment area. This is to prevent inadvertent contamination of the vial through direct or indirect contact with potentially contaminated surfaces or equipment that could then lead to infections in subsequent patients. If a multi-dose vial enters the immediate patient treatment area, it should be discarded after use. And this is information that is already on CDC's website, as you can see the link there, but also has now been placed into this general recommendations draft. Also in the section on vaccine administration, preparation, and timely disposal, we have language that reads, In certain circumstances in which a single vaccine type is being used, for example, in preparation for a community influenza vaccination campaign, filling a small number, 10 or less, of syringes may be considered. When syringes are filled, the type of vaccine, lot number, and date of filling must be labeled on each syringe, and the doses should be administered as soon as possible after filling by the same person who filled the syringes. Unused syringes that are pre-filled by the manufacturer and activated, that is, syringe cap removed or needle attached, should be discarded at the end of the clinic day. This language is marked in track changes in your document, but that reflects basically it being moved around. This is current long-standing general recommendations language and CDC, and therefore CDC guidance, as well as a common training message that CDC uses and adheres to really standard administration practices. These two sections taken together have recently engendered a lot of discussion in the work group. Because of the shutdown, the work group really didn't get a chance to talk among themselves, but they had a chance to see this slide set, and they saw the draft, and already there's been a lot of discussion in the work group on this. And I wanted to just make some summary points and explain kind of why this has been such an interesting issue. It has to do basically with mass clinics and how to apply these two concepts together in a mass clinic. On the one hand, you want to make sure that your multi-dose vials are free of contamination. You don't want them open near a patient. So there has to be some distance between the patient and the storage facility or the area where the syringes are going to be filled. And we also have a recommendation that the same person that fills the syringe may need to administer it. So there's going to be some rotation of staff, some feasibility issues. It's going to be inefficient. Many people have said this. And of course, the language about discarding doses that have already been opened also can lead to concerns about vaccine wastage. So just some summary points is that one of the issues is this is based on CDC guidance already on the website. It is on there because of this. It's been on there a while and has recently been discussed further by a separate CDC vaccine administration work group, distinct from any ACIP work group, which has the task of addressing vaccine administration and safe injection practices. It is true that that is a broader discussion, that it goes beyond vaccines, but there has been discussion about incorporating this content into the vaccine-specific Pink Book as CDC guidance. So this is something that we placed into the general recs as well. It's very, very strict guidance involving the use of multi-dose vials, and as I've mentioned, the pre-filling of syringes also would have to occur at a distance from the patient, presumably close to the storage unit. What about satellite clinics where the storage unit is close to the patient? Any small space, is this efficient or inefficient, or how inefficient is this? What are we going to do about this? So we wanted to have that as a discussion point, keeping in mind that the other half of this guidance about pre-filling syringes is specific ACIP guidance, the allowance of 10 pre-filled syringes. Manufacturer pre-filled syringes are preferred, but the end user can also pre-fill 10 syringes, 10 at a time, perhaps from one multi-dose vial only, and bring that to the administration area. The other aspect of preparation and timely disposal I did want to share, it's less controversial, is we're defining same day as the same clinic day. This has been a useful concept in general immunization practices, so that's also kind of new in this section. The other aspect of timely preparation and timely disposal involves changes that we made with respect to needle safety, and we wanted to do this to kind of remove what previously existed in the 2011 recs as both a strong and a weak recommendation in the same place. The strong side was their statement, this refers to the need to not only make sure that needles are not being recapped or they're not being removed, that the needles are specifically those engineered to be safe, All of this language comes from the OSHA regulations, and in the previous general recommendations, we stated that these federal regulations require that safety-engineered injection devices, needle-shielding syringes, or needle-free injectors be used for injectable vaccination in all clinic settings. So that's on page 4, line 6 of your current tracked draft. That was the strong side. In the previous document, you'll see now struck out a consideration preference type statement. Safety engineered needles and syringes or needle-free injection devices are preferred and should be encouraged to reduce risk for injury. We took that out. So that's another thing that we've talked about and a change to the general recs. Second vaccine administration topic is with the publication of the last general recs in 2011, it was published in January 2011, right before we really had a lot of use of the Fluzone Intradermal, so there was nothing on intradermal vaccination in the general recommendation. So we have now added this, page 11, line 3, to accompany, of course, a discussion of intramuscular, subcutaneous, as well as, of course, oral administration and intranasal administration of vaccines. So that's all in there now, including the new section on intradermal vaccination. And we've added some language to this based on communication with manufacturer to state that intradermal influenza vaccine injection of someone, that should say 9, I took that out, I'm sorry, I had to make some changes to the handout because the line numbers got in there. So that should say of someone 9 through 17 years of age can be counted as a valid dose on the presumption that their skin thickness is similar to, and then that 6 should not be in there, to someone 18 through 64 years of age. A dose of intradermal vaccine given to someone younger than 9 years of age or older than 64 years of age should not be counted as valid. So this is specific information about invalidating a dose of vaccine for one age group and actually validating a dose given off-label to the age group 9 years through 17 years of age, based on communication again with the manufacturer on the basis of variation in skin thickness. When it comes to vaccination route, this is our third and really last administration topic, we made a change to the needle length table. This is table 10. What you see up on the slide is the needle length table from the 2011 current document. This is for IM injections for children 18 years of age and younger, and there also is a part of the table not shown on this slide for adults 19 years of age and older. The changes with children, we used to combine children 3 through 18 years of age with respect to the needle length for the specific injection site. Based on 2 publications, this is what the current table looks like, and you'll see that we have now split out children 3 through 18 years of age. We now have a section for children 3 through 10 years of age and one for children 11 through 18 years of age. And the reason for this is 2 publications that have come out in the interim from Lisa Jackson and Amy Middleman on the appropriate use of these vaccines, or the availability to use these vaccines is not the preferred location site, but it's an alternate site for the anterolateral thigh, and there is some variation with respect to the maximal needle length that we would allow, and it's different for the 2 age groups, so we had to make this change. Also, with respect to route, there has been discussion, and this is ongoing discussion, about clinical implications of non-standard vaccination practices. And in your draft, this is on page 15, line 16 of your tracked copy. And I basically want to give some background to this. So, as you know, we do not recommend changing the route of administration, but we do make some vaccine-specific recommendations with respect to whether we count the dose or not. And we make a specific recommendation in the 2011 General Recs that states hepatitis B administered by any route other than intramuscular or in adults at any site other than the deltoid or anterolateral thigh should not be counted as valid and should be repeated. In earlier discussions in the General Recommendations work group, We addressed this topic somewhat when we discussed special situations and vaccination of persons with bleeding disorders, and we reaffirmed that we want to give discretion to providers if they don't feel comfortable about the bleeding risk, that they can in fact administer a vaccine, or rather that they have the option, as worded here, of not vaccinating intramuscularly. We say they should administer intramuscularly if a physician familiar with the patient's bleeding risk determines that the vaccine can be administered by this route with reasonable safety. So this was in the special situations section shared with ACIP at the February meeting. This raises the question, do subcutaneous doses of hepatitis B vaccine to persons with hemophilia need to be repeated? And this has led to collaborations with the Immunization Safety Office, with other vaccine-specific groups, specifically the hepatitis B vaccine subject matter experts. There are actually some issues with human papillomavirus vaccine on this issue as well, so there's been a lot of discussion. The 2011 General Recs vaccine routes section allows subcutaneous administration of meningococcal vaccine based on CDC immunogenicity studies that were done back in 2006 when the conjugate vaccine came out, and it was intermuscular instead of the subcutaneous pure polysaccharide vaccine. A lot of errors occurred. We did this study. We showed that you could, in fact, administer this intramuscular vaccine subcutaneously. But the section is silent on other vaccines, and so we looked at this. We found data on hepatitis A that demonstrated good immunogenicity if administered subcutaneously, so we added that as a vaccine to meningococcal conjugate vaccine, for which we would accept a dose given subcutaneously. However, for other vaccines, we have not reached a point where we have enough evidence where we think we can add it to the list with hepatitis A and meninge. Human papillomavirus vaccine, the package insert specifically states intramuscular administration. There's been a lot of guidance given that you should not count subcutaneous dosing of human papillomavirus vaccine, so that is currently where it is and remains, should only be administered intramuscularly. And then hepatitis B vaccine, there are ongoing discussions to actually conduct studies with the National Center for Birth Defects and Developmental Disorders to look at patients with hemophilia and their response, their immunologic response to subcutaneous dosing of hepatitis B vaccine. This is being done out there. It's common practice for providers to administer the doses subcutaneously. It's on the order of 20%. And so these studies are underway. So as you'll see from your draft, we list hepatitis A, we list meningococcus, but we don't really make other changes for the other vaccines. But I wanted to share that ongoing discussion. Okay, now shift to your vaccination records handout. And I don't have a lot to say here before handing the mic over to Stuart Myerburg, but I do want to talk about a couple changes. First of all, with respect to the provider records section, we wanted to add some language, which is probably overdue, that clarifies which specific vaccines are covered by the National Vaccine Injury Compensation Program. And so we added this following language. This act applies to any vaccine for which there is a routine recommendation for childhood vaccination, whether administered to a child or adult, and even if many or most doses of the vaccine are administered to adults, for example, influenza vaccine. So that's page 1, line 13 of the vaccination records section. This is, of course, relevant because there are specific recording requirements for the National Vaccine Injury Compensation Act. What date the vaccine was administered, the vaccine manufacturer, the vaccine lot number, name, address, title of the person administering the vaccine. What I didn't place on the slide, also in the law, is the date of the VIS administration, and also the fact that the VIS was given. So those are specific recording requirements of the Act, and we want to clarify because, of course, for instance, influenza vaccine is a vaccine that we used to think of traditionally as an adult vaccine, but now, of course, there is a recommendation to administer the vaccine to children, so it, of course, also is covered by this Act. So basically language to clarify that. Also in vaccination records, in the heading on immunization information systems, we have placed new language which you can look at in the draft that highlight what functions are carried out by an immunization information system, or IIS, and the following listed on this slide. This is page 2, line 17 of your draft. IISs can prevent duplicate vaccinations, forecast when the next dose is due, limit missed appointments, allow recall for those who missed appointments, determine when vaccines need to be repeated, which is akin to, I think, a language that we'll become more and more familiar with. We call that evaluation. Reduce vaccine waste, and reduce staff time required to produce or locate vaccination records or certificates. So what is new to the draft this year are this particular language about forecasting when the next dose is due, allowing recall for those who missed appointments, and determining when vaccines need to be repeated, or evaluation. So those are the new terms. And we also placed language into the draft on line 19 of page 2, statement that IIS should maintain interoperability with other electronic health record tools as part of an effort to improve the quality of care, reduce health disparities, engage patients and families in their health, improve the coordination of care, improve population health, and ensure adequate privacy and security protection for personal health information. And the reference for this is also on CDC's website. We imagine that, depending on the duration of the process for publishing the general recommendations, we might make further changes, perhaps get more specific with different phases that have occurred, but for the most part we haven't got into that just yet. Think of that as placeholder information, but right now this is kind of our reference to kind of interoperability with the electronic health record, and harkens back to the Meaningful Use website. And so, based on the bullet points that I gave you for IISs, I wanted to now turn the mic over to Stuart Myerburg. He's going to be discussing a clinical decision support tool for immunizations, also known as CDSI. You should have, ACIP members should have a copy of a pamphlet that highlights this project. And I will now happily turn the mic over to Stuart. And then we'll take questions on both sections altogether afterwards.
Thanks, Andrew, and I'll just wait a moment till the presentation comes up. I'm going to be giving a very high-level overview of our clinical decision support for immunization project. The pamphlet that Andrew mentioned that you have goes into a little bit more detail about it. So we're talking about the background of the project, and then what our results were, and what our next steps are. So the first thing is just what do we mean by clinical decision support? So as Andrew mentioned, it's more commonly referred to as vaccine forecasting and evaluation within the immunization community. And that function is performed by many different computer systems, electronic health records, and immunization information systems, and then also just standalone applications like web-based schedulers, smartphone apps, and things like that. All these systems work independently in developing their logic and their code. And so that kind of, the reason is that we have this project is because of that. ACIP schedule integration into computer systems is challenging. The schedule is communicated for humans to read, but obviously computer systems can't read a narrative or a schedule. So those recommendations are then taken by subject matter experts and technical people who are developing the computer systems, and they interpret it and try to code off of that. That can be very time consuming, and it's happening independently, so there can be variability. So the output from these evaluation and forecasting systems can vary widely, and the results don't always match the results that clinical experts expect, or what you would expect if you read the ACIP recommendations. And this is really because each one is developing its own system. They're coding off of the language and then trying to make their own interpretations. A 2009 study by the Immunization Information Systems Support Branch showed that there was definitely ambiguity in their interpretations. 36 algorithms from forecasting systems were looked at. 9 test cases were run against those. And the results showed that 19 of those 36 systems, or 53%, forecasted the next dose 5 days or greater than the minimum age. So obviously there was some variability. And of course the reason for that is, as we all know, the immunization schedule is complex. The schedule changes frequently. And as I said before, these computer systems are decentralized, and so they're not sharing any sort of common technology or logic framework. So even if a system is interpreting the recommendations correctly, it can often be very specific to just that given application, and so there's no sharing of that information. So if one system is doing it correctly, it doesn't mean any of the other systems are. So of course there's disparity as a result of that. As I said before, the logic that is created for these systems is really based on just a human or humans looking at the schedule and trying to interpret it and make it into code. Also, there's really no consensus on how to represent these logic for computer systems, and many of the standards that are being used are very proprietary. So as a result, we started this project, and the Clinical Decision Support for Immunization project was meant to bridge that gap between the ACIP recommendations that are published in scientific language and human readable and the IT world of computer systems. What we wanted to do was create something that could be used by all of these systems. We recognize that there's variability in tools being used, code being used by these systems. So we didn't want to create a tool. We also didn't want to create anything that was proprietary. So what this is just a way for any software system to be able to take the logic and move it into their system. So hopefully that would promote consistent interpretation of ACIP recommendations across these computer systems. And of course the ultimate goal is to ensure that a patient's immunization status is current, accurate, and consistent. So as I said before, the problems were really variance, complexity, and disparity. And so our goals were to address the variance, to document the logic for applying the rules so that the computer systems would have consistent interpretations. We also wanted to make sure that when there are changes to the schedule, that those can be quickly incorporated into these computer systems. And also just make sure that we catalog the ACIP rules consistently. So just to clarify, obviously these are not new vaccine recommendations. What we really wanted to do was just catalog the existing ACIP recommendations. The first part of this project, we just looked at healthy children from birth through 18 years, just to limit the scope because of time. This is not a software application, so it's not something you can download and then get a recommendation or an evaluation out of. It's just the logic to be used within computer systems to create consistent logic within them. It's also not a replacement for current computer systems. We recognize that there are some very mature systems out there within the IIS and EHR communities that are doing very well, and we don't want, or they don't want, to replace their systems. So really this was meant to be clarification and validation, but if somebody wanted to create a new system based on these rules, obviously they could. So this is a little bit of a graphical representation of the before and after. So ACIP recommendations are made, and EIPB, Andrew's group, makes clarifications, and then for the information on the right, What was happening is each system was looking at those recommendations, getting clarifications, manually interpreting and coding, and then sending out their automated response, and they weren't matching up. So what this project hoped to do was to take those ACIP recommendations, come up with one logic specification that everyone could code off of, and then have one consistent interpretation. So the outcomes provides a uniform recommendation across all entities doing immunization evaluation and forecasting. Keeps those recommendations up to date and consistent. And it allows for broad use of a variety of technologies. So basically all those goals that we talked about in the previous slide. Earlier this year, the logic specification was published at the end of last year in October. And then earlier this year, we did a very informal evaluation feedback just to kind of see the pulse of the community. The preliminary results showed that of the 42 respondents, 80% found the resources to have a somewhat or very positive impact. And of the people using the resources, 94% said they would use the logic specification, 100% said they would use the supporting data to modify their systems or seek clarification. So it's basically being used the way we had hoped that the community would be using it. And others commented that they would use the resources if they were redesigning their systems. So next steps. We have resources in place to maintain the logic, so when there are changes or clarifications, we can update the resources. We just got funding to do the adult vaccines, so we will be doing the same logic for the adult schedule. We're also going to be tackling underlying conditions as part of that project. It's something that we had tabled during the initial, just because of time and resources. But we recognize there needs to be a standard way to have consistent electronic codes for the underlying conditions. And that's especially relevant for the adult schedule, but it will also impact the childhood schedule as well. Then also, I said that we had done an informal evaluation. We want to put in place a more formal evaluation plan to really determine impact and uptake. So just the take-home points. So we designed the resources to work with a variety of computer systems. We didn't want to create a tool of any sort. We just wanted this to be something that could be used by all the systems that are already out there. And it's providing clarity and consistency to those ACI recommendations that are coming out of computer systems. And we recognize that it needs to be adjusted in parallel with any sort of changes or clarifications that occur from ACIP. And that's it. The pamphlet, like I said, has a lot more information. It also has the website for all the resources. And I think now we'll just be opening up for questions for me and Andrew.
Dr. Duchin.
Thank you for that. But before we go to questions, can you bring up my last slide, please? In my haste to get on to the meat of the presentation, I neglected to acknowledge the ongoing contributions of our work group members. So I want you to be able to see the work group members, and I want to express my appreciation for their ongoing work on this. And I also wanted to especially call out Andrew's competence in leading us through a very broad range, as you can see, of diverse issues related to the seemingly never-ending work of updating the general recommendations. So thank you, Andrew.
Dr. Herman.
So I love the work you're doing on the computer systems. I'll just say that. But my main comment was about the general recs, and I'm just wondering if under the vaccine preparation section, you might want to add something about the pertussis DNA contamination issue, and preparing pertussis-containing vaccines separately from where you might be doing swabs of patients and getting contaminated PCRs and so on.
We actually haven't yet had an opportunity to kind of fill in that information, which is part of the injection safety office, with some specific examples that could help strengthen that. So I think we can look into giving some concrete examples to help support that policy. I'm not really very familiar, I must say, right now with that particular issue, but I will bring that back to the work group.
Yeah, the pertussis team has nice guidance, and it's on the web.
Dr. Kempe, or Dr. Kemp, I'm sorry.
Okay, Dr. Tempt. I have one comment and then actually several questions about the data issues. One comment about the RECs. I think the phrase inclusion of adults into IIS also would be worthwhile. I think that should be a lot stronger. I think this should be strongly recommending that adults be part of IIS. There's so much evidence about the effectiveness of IIS-based tracking and recall that could be applied in the adult scene, and I think this should be much stronger. My questions about the data systems are, of course, the devil is in the details. We've been working a lot with our state registry, doing a lot of centralized reminder recall, and because of that process, and only because of our research, we became aware that different reports from the same system were recommending different children. Part of that had to do with very rapidly changing codes. I mean, PCV7 to PCV13. And all of that requires constant updating. So is your program capturing that type of data about changing codes for vaccines, number one? And I guess my other question is, how can conscientious looking at these reports be encouraged by CDC? For example, what can be the carrot for IIS, state IISs, to be really looking critically at these reports, because they're all underfunded and they're all under the gun and working way too hard? Thanks.
Right. Well, as far as the codes go, it's not directly related to the CDS project, but we do keep updated code sets on our branch website. So that is done and is available to the community. As far as the carrot, well, as far as getting the information out there, we have been working very closely with ERA and other organizations to make sure that anytime we make any sort of update, that gets distributed out to the community. We also have a place for anyone who's interested to sign up for updates whenever we make changes to the resources. So that also will capture, because we mainly are in contact with the IIS community, but that also allows us to capture the EHRs who may also be interested in it. As far as the carrot, I think it's just that it is very time-consuming and complex, and so I think that the incentive really is just that it takes that burden off of the people who are working within the program. This is now there for them to just go to, and it saves them a lot of time. So I think just by default, it's a carrot just by existing. So at least I hope so.
Ms. Stinchfield.
Patsy Stinchfield from NapNap. Andrew, this one's for you. On the section on multi-dose vial, and I appreciate that you gave a little bit of wiggle room for mass clinics such as influenza vaccine clinics, but I think we still have some work to do on that, in that it's quite prescriptive, overly prescriptive in speaking about drawing up only 10 numbers of vaccines at a time, that the person who draws it up has to be the person who gives it. In an emergency situation, that just won't be followed. And I know, because I've been through this more than one time, that won't be followed. The way I think that we can address some of these things, because I know we're all nervous about multi-dose vials and problems that come from that, is talk about the principles. So making sure that we are following principles of safe storage and handling, following principles of infection control, of medication integrity and safe handling and those kinds of things. But we had 6 kids die in a 2-week period of influenza in 2008, and were overrun by people wanting vaccine in January. And setting up a mass flu vaccine clinic, we were able to vaccinate 2,000 kids in 3 hours. But we had the pharmacists drawing up the flu vaccines, putting them in labeled buckets, and then bringing them to the nurses who stayed in the rooms and then vaccinated. And we would not have been able to really manage the onslaught of people if we had to label each individual syringe. So I just think we need to kind of be a little more practical and come to the middle on that one.
Definitely good advice. There's going to be some wiggle room in the implementation part of any recommendation that comes out. With respect to this, obviously, in today's discussion with respect to safety needles, we wanted to not be strong and weak in the same paragraph. So there we kind of became very prescriptive. But I guess I can see the point of erring a little bit on the other side of leaving things vague enough so that people can actually do what they need to do.
Dr. Lett?
Yes, I just wanted to, I was going to say many of the things that Patsy said, and I really would encourage you to think about that wiggle room for large clinics. But and I've talked with Andrew, and I'm on the working group. I think that a number of us are also concerned about this language around multi-dose vials in the exam room, and I think that it does have preservative in it, and I'm assuming that they're trying to decrease the possibility of nosocomial transmission and maybe drug diversion or some other problems. But I think that we could actually result in a lot of vaccine being wasted for for influenza vaccine, which is really the only thing, and maybe one other vaccine that comes in a multi-dose vial that's given to children. And so, I am really concerned about that language emerging in the pink book. And so really, I welcome the opportunity to have more discussion about that in the work group.
Dr. Duchin?
Just a quick follow-up to Dr. Kemp's comment. It's very consistent with the new NVAC standards to promote the use of adult immunization systems. And in that context, because we have many fewer vaccines, but perhaps a very complicated situation with the pneumococcal vaccines, I was wondering if you're aware of any progress that's been made around information system support, decision support for administration of pneumococcal vaccines to adults, with the various vaccine formulations that are available, the various permutations of risk factors, the intervals depending on which vaccines administered first, and so on and so forth.
Well, the adult project literally started the day of the shutdown. So we haven't tackled any of those issues yet, but we'll be doing the same sort of process we did for childhood, which is, gathering SMEs from across the gamut. And so we'll be gathering all sorts of scenarios like that and tackling them. So not yet, but hopefully soon.
Dr. Moore?
Thank you, Kelly Moore with AIM. With respect to the IIS statement, actually on the vaccination records, given that the meaningful use funding goes to the practitioners who are implementing electronic health records, I would suggest flipping the sentence to say that electronic health record tools should maintain interoperability with the IIS, because we are ready to receive their information in our IISs, and it's up to the health record tools to actually work with us to make that happen. And we are already, like many states, a lifelong registry. And definitely want all records for all ages. Also, I want to underscore Dr. Lett and Patsy Stinchfield's comments about the multi-dose vials. I think a statement that if a multi-dose vial enters the immediate patient area, it should be discarded after use is a bit too prescriptive and impractical, especially not just in mass clinics, but in very small clinics and small health departments where you may not have a lot of different rooms in which to operate. Thanks.
Dr. Caserta?
Thank you, Vito Caserta from HRSA. On the slide that covers the Vaccine Injury Compensation Program, it states that the Act applies to any vaccine for which there is routine recommendation for childhood vaccination, whether administered to a child or adult, or even if most doses of the vaccine are administered to adults. And you give the example of influenza vaccine. I suggest you say seasonal influenza vaccine because the program does not cover pandemic influenza vaccines, and we wouldn't want to confuse. In addition, that's technically not complete because an excise tax also needs to be imposed before it's covered, and the Secretary needs to formally add it to the table through a notice in the Federal Register. So I mean, I guess it's true, but it's not technically correct. The other point is when you talk about injecting into the deltoid, we've had dozens of cases in the compensation program of bursitis where the injection is given too high in the deltoid. So if there could be added some language where we say to avoid the upper deltoid, I think that would be helpful.
Okay, we can make that change.
Dr. Lehr.
With respect to the OSHA regulations, you said that these federal regulations require the safety engineered injective devices. My interpretation is that that's actually not true. OSHA does not require employers to institute specific devices, but it does require that employers evaluate the effectiveness of existing controls and review the feasibility of instituting more advanced engineering controls. So my understanding and interpretation over the many years has been that employers have to look at it every year and evaluate it, but you don't actually have to implement it.
That's just going to be an issue of, looking at the specific URL and seeing what it says. And because if I understand you correctly, it's the interpretation of the general recs, what the law states, is an error?
My understanding is the weak, on your slide 7, the weak statement you had is more accurate from the way OSHA is interpreting the law, that you do not actually have to have that. And so if you put the strong statement in there, the federal regulations require, that's not what OSHA requires. So maybe you have to go back and look at the OSHA and have someone else interpret it, but that's my sense.
Okay, we'll do that. We went to the website, but we can go back and verify.
And Ms. Groom.
Thank you. I first just want to commend CDC on the CDSI project. It's been fantastic, and we're so grateful to have that resource out there and are really looking forward to the work on the adult stuff, especially around pneumococcal vaccine. On the IIS issue, Kelly, I know states work really hard on this, but providers also are working really hard on this, and we actually have situations with states that actually are not able to receive our records. And so I think that IIS EHR interoperability really is a partnership, and maybe the language could be changed to reflect that. And then just with regards to Dr. Kemp's question about the codes, we've really come a long way on that process, but we still do get caught up with some one-offs, such as the quadrivalent flu vaccine. We had to have a new code for the preservative-free and preservative-containing formulations, and that didn't come out until the middle of August because of the last-minute approval of that, and so that does catch us off guard. But we have come a long way, and CDC's been very responsive when those situations come up, very quickly getting the code. So continuing to work on that would be great.
One additional comment here, just in terms of the comment here on underlying conditions and documentation and the electronic codes. This is a two-way street, and I think it's inherent for the work groups to really think carefully about not only the conditions, but go to the ICD-9 manuals and pull out the codes and the range of codes that can help educate the programmers, because we're really close to this. But without having and it's innumerable codes out there, but they're actually pretty easy to do the logic. And this also applies to, we're able to pull medications, so we can identify people who are on chronic corticosteroids at this point in time. And these are all things that, for some of the vaccines, are going to be important. Other questions? Dr. Schaffner.
Thank you. Bill Schaffner, NFID. I wonder, Andy, if you have addressed in the recommendations the interstate compatibility of the IISs. Can they communicate with each other? If I'm in one state, can I access the information system in another state, the registry?
We don't. I mean, what was in the draft does not go into that kind of detail. The general recs draft where it discusses IIS, so that apart from the fact that we're talking about maintaining interoperability with electronic health records, and that may engender cross-state, but we haven't gone into those types of details now.
Well, children, I'm sure, on occasion, but adults a lot, move between states, and this is a real barrier in using registries in order to maintain immunization records. I think it might be nice to address this.
Yes.
I'm Gary Urquhart, the Chief of the Immunization Information Systems Program. We have a couple of initiatives to address interstate data sharing. It is a very complicated issue. All states have privacy and confidentiality statutes, and interstate data sharing is not technically a big problem, but the administrative aspects of it are. So we have some initiatives with the Office of the National Coordinator and with others to try to get this, maybe find some solutions to this or best practices for that.
Dr. Sawyer?
Having participated in this clinical decision support process and tried to unravel the complicated logic that the well-meaning ACIP created in their recommendations, I would also ask each work group to be very mindful of the computability of their recommendations, and if better than that, consult with an IIS colleague before you make recommendations that we later have to unravel again.
And Ms. Pellegrini.
I think it's important just to note in the context of this conversation about IISs that while we're thinking through the medical and the scientific issues, there are these privacy issues, and there are people who are not comfortable with a government entity holding their medical information or this degree of their medical information. They may be comfortable with their doctor doing that in an EHR, but when it goes into what some people perceive as a large government database, and then we talk about starting to share that across state lines, these are things that we need to be mindful of and tell people how we're going to protect their privacy in the process.
Any additional comment? Okay, thank you very much.